Whilst people are joining us this afternoon, I'll commence by welcoming everyone to the DARIA series, which is the Drug and Alcohol Research and Innovation Active Learning Network. DARIA is a virtual weekly seminar program delivered by St. Vincent's Hospital Sydney Alcohol and Drug Service and the National Centre for Clinical Research on Emerging Drugs in collaboration with Southern New South Wales Local Health District, Murrumbidgee Local Health District, and Far West New South Wales Local Health District, as well as Western New South Wales Local Health District. The aim of this series is to promote innovative practice and share learnings and new ideas amongst clinicians and clinical researchers working in the field of methamphetamine, emerging drugs, and other areas of alcohol and drug health. I'd like to start today by acknowledging and paying our respects to the traditional custodians of the lands and waters in Australia and all of the First Nations elders, past, present, and emerging, especially those who are joining us here today. We respectfully acknowledge the traditional custodians and their continuing cultural, spiritual customs and practices. I would like to welcome our speaker to this week's DARIA session. Dr. Thileepan Naren is an addiction medicine advanced trainee at the Western Health in Melbourne, as well as a general practitioner. He also hosts a really cool podcast. If you get a chance to listen, I recommend it. It's Cracking Addiction, and it's available on all the normal podcast places. And without further ado, Thileepan, I will hand over to yourself. Thanks everyone for joining.
Thanks, Krista, and thanks very much for having me. So as Krista mentioned, my name's Thileepan Naren, and I'm going to be talking about Kamini VIDRAWAN RUS. Before I start, I'd also like to acknowledge that the land on which I'm presenting from today is the traditional land of the Wurundjeri people of the Kulin Nation, and that we respect their spiritual relationship with the land. We acknowledge that sovereignty was not ceded and that Aboriginal people experience a disproportionate burden of disease as a consequence of colonial occupation. We commit to work with the traditional owners of the land to minimise and eradicate this harm. And we pay our respect to the Wurundjeri elders, as well as all Aboriginal elders past, present, and emerging. I thought I'd start this presentation off by first going through a couple of case studies of some of the patients that I saw with Kamini. So the Kamini dependence and addiction. So the first patient I'm going to present is a 39-year-old Indian man who was referred to the addiction medicine clinic by his GP due to, and I quote, Kamini addiction. The first consultation was a phone consultation. And Kamini or Kamini VIDRAWAN RUS is an Ayurvedic herbal preparation containing opiates. So with regards to his substance use history, the Kamini was initially prescribed by an Ayurvedic physician in India to increase energy and vitality for the patient, and he had been using this for the last 5 years. He was initially prescribed 1/2 to 1 tablet daily, but his usage soon increased and he was currently taking 7 tablets twice a day when he saw me, which was down from his peak usage of 7 tablets 3 times a day, which he had weaned himself down from, but he found himself unable to wean himself any further from 7 tablets twice a day due to unbearable withdrawal symptoms. He reports that he took the tablets to increase energy and stamina, and he takes the tablets daily with no tablet-free days. The withdrawal symptoms when he does not take the Kamini included a runny nose and watery eyes, generalized aches and pains, anxiety, and yawning. He reports that he swallows the tablets with no injecting of the tablets. He reported no current impact on his work, but his wife was unhappy with his ongoing substance use, and it was impacting his finances as each of the bottles of the Kamini was costing up to $200 per bottle. With regards to other substance use, he was drinking 1/2 a bottle of whiskey 1 day per month in a single setting. There was no daily drinking and no alcohol withdrawal symptoms. He smoked 1 to 2 cigarettes daily and had been smoking at this level for the past 12 years. He had no past withdrawal management or rehabilitation admissions, and he had no legal or forensic history. He had no past medical history, no mental health history, no family history of substance use disorder. He had no regular medications that he was taking, and he had no known drug allergies. He worked as a construction worker and still was able to manage working full time. And he was married and living in his own house with his wife and had no children. So with regards to the patient's goals, he was quite explicit that he wanted to, and I quote, come off Kamini. He had a strong desire to cease Kamini use and was upset and embarrassed that he could not stop using this substance by himself, and the discord that it was causing between himself and his wife, and the growing financial impacts. So we discussed potential treatment options, including a slow wean off Kamini, a potential for the residential withdrawal admission and symptomatic management of withdrawal, and the consideration of using buprenorphine or Suboxone short-term as a bridge to aid in withdrawal management, and also the option of opioid substitution therapy, and in particular Suboxone, and consideration of a long-acting injectable buprenorphine. And the patient elected to commence on opioid substitution therapy. So the issues that we had to consider was, is this opioid use disorder? And it does seem that this patient meets the DSM-5 criteria of at least meeting two of the criteria for opioid use disorder, in that there is a persistent desire or unsuccessful effort to cut down or control opioid use, and there was a craving and strong desire to use opioids. He also seemed to meet the tolerance and withdrawal criteria. However, the argument is, if this was a previously prescribed and maybe a culturally appropriately used medication, one might not necessarily be able to use the withdrawal and tolerance criteria for the diagnosis of opioid use disorder in this patient. The other questions were, when do you stop taking Kamini? Given that this is an over-the-counter and unsanctioned medication in Australia with an unknown amount or type of opiate, there was no definite certainty on the half-life of this opiate and when would be prudent to stop. And what is the risk of a precipitated withdrawal, particularly when starting buprenorphine? Similarly, given no indication of the strength of opiate in Kamini, what dose of Suboxone should one start on? So there were quite a few questions to think about. For the second appointment, he presented face-to-face, and a urine drug screen was positive for opiates. We broached stopping the Kamini for 1 day and then presenting in withdrawal for assessment and commencing Suboxone. However, the patient felt that this was impossible due to significant opiate cravings. The compromise that we came up with was that the patient would take 2 tablets of Kamini in the morning and present to the pharmacy in the evening. And if he was in opiate withdrawal, he would have a test dose of 2 milligrams of Suboxone and then a further 2 milligram dose 1 to 2 hours later if needed. Ultimately, the transition to Suboxone was completed successfully. The patient took the 2 Kamini tablets in the morning and presented to the pharmacy in the evening with what he reported were significant withdrawal symptoms, and had the 2 milligram test doses of Suboxone and then the further 2 milligram dose 1 to 2 hours later. He was up titrated by 4 milligrams per day, and ultimately the patient was stabilized on a dose of 12 milligrams of Suboxone and was able to cease using Kamini. Case study 2 is a 34-year-old Iranian man who was referred to our service for opioid substitution therapy. His substance use history includes opioids, prescribed opioids post a motorbike accident 13 years ago in Iran, and post developing opioid dependence was commenced on methadone in 2018 in Australia. And I'll discuss this history further in the next slide. He also smokes 20 cigarettes a day, which he started smoking at the age of 16. He reported a previous heavy alcohol intake, but ceased this upon commencing methadone, and reports previously being prescribed short courses of benzodiazepines, but had not been using any benzodiazepines for a number of years. And he denied any other substance use history and no history of injecting drug use. So with regards to this gentleman, he reports he was given morphine whilst in hospital in his home country of Iran following his motorbike accident 13 years ago, and was discharged with tramadol. He was initially prescribed 200 milligrams per day, but would take up to 1,000 milligrams per day. After he had moved to Australia in 2011, he reports he was started on Panadine Forte at a quantity of 3 tablets per day, but this increased to 11 tablets per day, and he reports all of this was prescribed. He was then prescribed OxyContin 10 milligrams per day, and then his GP changed this to Suboxone and then Methadone in 2018. The patient was prescribed 160 milligrams of Methadone per day by his GP, and the dose was apparently split between 2 pharmacies at a dose of 80 milligrams at each of the pharmacies. And this was allegedly under the doctor's instructions. Unsurprisingly, the Department of Health and Human Services wrote a notification letter to the GP about this prescribing, and the GP then wrote a script or reverted the script to a single pharmacy and cut the dose immediately to 95 milligrams of methadone. Unsurprisingly, the patient went into opiate withdrawal and reports that in addition to the prescribed 95 milligrams of methadone, he was able to acquire 35 to 40 milligrams of methadone from non-prescribed sources and would take 10 to 11 tablets of Kamini to manage his opioid withdrawal symptoms, which were quite significant. And he describes sweating, pain, anxiety, and flu-like symptoms, as well as agitation as being those withdrawal symptoms. The patient was then referred to our addiction medicine clinic, and post his methadone dose being up titrated, his Kamini usage ceased, and the patient is currently stabilized on 220 milligrams of methadone daily. So those 2 case studies feed into the general body of the talk, which is basically what is Kamini VIDRAWAN Rus. So Kamini is an opiate-containing Ayurvedic herbal medication. It comes in the form of tablets or pellets, which are swallowed whole, and it is promoted as a cure for impotence, premature ejaculation, oligospermia, decreased libido, and erectile dysfunction, but also for increasing energy and stamina. It's readily available over the counter in India and prescribed by traditional Ayurvedic practitioners, and is also available in Indian grocery stores in Australia, also over the counter. So Ayurveda, or Ayurvedic medicine, is a system of traditional medicine native to India. Ayurvedic techniques include dietary changes, herbal medicine, including combining herbs with metals, minerals, or gems, and this is known as Rasha Shastra medicines, and that can take the form of pellets, tablets, and powders of various colors and scents. Ayurveda also includes massage, meditation, breathing exercises, and something called Panchakarma, or the 5 actions, a specialized treatment consisting of 5 therapies, including emesis or vomiting, enemas, and bloodletting. And this is thought to detoxify the body and balance the doshas, or the body's 3 vital energies. Ayurveda also includes sound therapy, including the use of mantras and yoga. And alongside diet, herbal medicine is central to Ayurveda treatment. In India, Ayurveda is considered a form of medical care equal to conventional Western medicine, traditional Chinese medicine, naturopathic medicine, and homeopathic medicine. And practitioners of Ayurveda in India undergo state-recognized, institutionalized training overseen by the Central Council of Indian Medicine. So these are the listed ingredients of Kamini VIDRAWAN Rus. And as can be noted, most of these are herbal extracts. The Shuddha Aphifena, and I apologize, my Sanskrit is terrible, but that is the Sanskrit name for Papaver somniferum, commonly known as the opium poppy. And the opium poppy, as the name indicates, is a principal source of opium and contains lots of opioid alkaloids, including morphine, codeine, thebaine, oripavine, papaverine, and noscapine. And out of interest, the Acarocara that's listed here is the Sanskrit term for the Anacyclus pyrethrum, or the Mount Atlas daisy. And that's a species of flowering plant in the daisy family. And extracts of Anacyclus pyrethrum have an anabolic activity in mice and are also thought to increase testosterone in the animal model. And in Ayurveda, this ingredient is thought to increase sexual desire and sexual performance in men. Of note, the toxic effects of Kamini are well known, with multiple case studies and case reports highlighting instances of heavy metal and lead poisoning post-chronic ingestion of Kamini. As per the product information, Kamini VIDRAWAN RAS is normally recommended at a dosage of 125 to 250 milligrams per day, or half to 1 tablet daily. If consuming in tablet form, it is recommended that tablets be consumed with milk or butter 1 hour before going to bed. The pills are handmade and variable in size, thus making the above dosage difficult to comply with. Chemical analysis performed on a sample of tablets in the same bottle showed a variability between tablets of 2 to 20 milligrams of opium. And chemical analysis of the tablets again revealed opium alkaloids, such as previously mentioned, codeine, morphine, papaverine, and noscapine, but also traces of heavy metals such as lead, arsenic, and mercury. The usage of Kamini VIDRAWAN RAS ties in with different cultural conceptions and views of medications as a whole and different medical philosophies. An article by Dhaliwal, based on an undergraduate thesis entitled Sikh Punjabi Masculinity and Barriers to Mental Health and Addiction Supports, describes societal expectations of Punjabi men to work hard to provide for their families and the social stigma around mental health issues. It is apparently also culturally acceptable to use substances to increase productivity and deal with stress, and opium has a long history in the Punjab, with many farmers used to taking opium prior to performing physical labor on a farm. Of note, upon emigrating to other countries, some cultural norms and beliefs can be retained, which can be at odds with the countries that these men are emigrating to. And what was once viewed as culturally acceptable practice is in another culture labeled as aberrant behavior. In recent years, there's been an emergence in Western countries of traditional medications with opioid content, such as bashasha and kratom. Traditional views on the role of medications can be precipitating and perpetuating factors for ongoing substance usage and could lead to poorer health outcomes. And treatment for patients with dependence to Kamini should include culturally appropriate and specific education about the constituents of Kamini and the dangers that could arise with ongoing consumption of Kamini. The literature surrounding Kamini VIDRAWAN RAS and treatment and management options is quite limited and mainly based around case reports and case series. The first documented report was a case study from 2010 about a 35-year-old man who became dependent on another opioid containing Ayurvedic herbal preparation called Bashara, and then switched to using Kamini and was treated with naltrexone pharmacoprophylaxis, psychoeducation, motivational enhancement, and psychosocial rehabilitation. There was no information on long-term adherence to this regimen and if this patient made a sustained recovery. There's another large case series of 10 men from New Zealand who were dependent on Kamini VIDRAWAN RAS and bashasha. This series was from 2013 to 2020 and included, as mentioned, 10 men. All of the patients were treated with opioid substitution therapy. 9 out of 10 remained in treatment at the time of publication of this report, and 7 out of the 10 were abstinent of Kamini and bashasha. There is limited Australian experience of Kamini VIDRAWAN RAS, and in Australia, the first report started with these 2 case reports. The first case report was on 2 patients who were dependent on Kamini VIDRAWAN RAS, who were treated with opioid substitution therapy. The second case report was of a patient taking 18 Kamini tablets per day, who was then stabilized on a 96 milligram Buvidal injection for 2 months before discontinuing treatment. A case series that was published around the same time as ours from Queensland showed a group of 12 men, 11 of whom were born in India, presenting with symptoms of opioid dependence and later diagnosed with opioid use disorder secondary to Kamini. The patients had taken Kamini for a variety of reasons and reported that they used it for the following reasons: increasing their ability to work longer hours or relieve stress, while one used it for dental pain. 6 patients were stabilized on maintenance treatment with buprenorphine naloxone. 3 patients responded to long-acting injectable buprenorphine, and 2 patients with no history of injecting drug use or other significant substance use received withdrawal management treatment with buprenorphine patches. Which brings me to the definitive work on Kamini in the literature, and that was just a bad attempt at a joke, but that's our case report and case series on Kamini. So the above table summarizes the patients that were identified to have used Kamini VIDRAWAN RAS at our service. The first 10 cases are patients who presented seeking treatment for Kamini VIDRAWAN RAS dependence. Case 11 has been discussed as the second of the 2 case studies I presented earlier. And case 12 presented to our service due to heroin addiction, but had disclosed that 2 to 3 years prior, he had used combinations of heroin, opium, and Kamini VIDRAWAN RAS when he was in India. He had been abstinent of all substances for 1 year, but post-emigrating to Australia, relapsed to using heroin, for which he sought treatment from our service. This case series highlights an interesting cohort of predominantly North Indian men from the Punjab region, which was 11 out of the 12 cases we described, who became dependent on Kamini VIDRAWAN RAS, suggesting particular cultural views of this medication. Interestingly, the cohort consists only of men, likely reflecting its usage as an aphrodisiac. Most of the men, 10 out of the 12, are still current patients of our service and attend the service regularly for opioid substitution therapy, with length of time in the program varying from 5 months to 7 years. Case 7 and case 8 were the 2 patients in this cohort who are not currently actively engaged in treatment, with case 7 dropping out of treatment after 2 months and being lost to follow-up, and case 8 moving interstate, and his ongoing engagement with addiction medicine services is not possible to be ascertained. Most of the men in our case series, 6 out of the 12, had no previous substance use history. The vast majority of the men in our case series, 10 out of the 12, remained engaged in treatment, and the majority of these men who have remained engaged in treatment, 9 out of these 10 patients, have returned to full-time employment and an increased ability to meet their personal and professional responsibilities, suggesting significant recovery capital within this population group who are searching for treatment and potential for a sustained recovery. So the current treatment and management of Kamini VIDRAWAN RAS dependence is based around opioid substitution therapy. Induction of patients onto Kamini, in our experience, has not been dissimilar to other patients with opioid use disorder. It has sometimes proven difficult to provide patients accurate advice on when to cease Kamini, particularly with induction onto buprenorphine as opioid substitution therapy, due to the variable opioid concentration in tablets, and the clinical advice provided is to present when in opiate withdrawal for the clinician or pharmacist to perform an assessment on their withdrawal status prior to commencing opioid substitution therapy. Dosing of opioid substitution therapy followed the standard conventional guidelines for induction onto opioid substitution therapy, with no adjustments required to accommodate for patients with Kamini dependence. The evidence base for opioid substitution therapy is mainly based around the harms and risks associated with heroin, and the benefits of opioid substitution therapy are well known and acknowledged for the treatment of heroin dependence and prescription opioids. A similar evidence base does not exist for Kamini VIDRAWAN RAS, and there is no significant documented literature on rates of overdose or death directly attributable to Kamini usage. So the question does arise, is this the most appropriate treatment? Do the risks or harms from opioid substitution therapy outweigh the benefits? And are there any other alternative treatments? In 2016, Kamini VIDRAWAN RAS tablets became prohibited imports under the Customs Prohibited Imports Regulations Act of 1956. And the supply of Multani Kamini VIDRAWAN RAS tablets and Ayurvedic Kamini VIDRAWAN RAS tablets in Australia is illegal. The TGA and Border Force are working together to prevent the further importation of these tablets into Australia, where they will be seized or impounded. However, despite these TGA restrictions, Kamini is still readily available. Anecdotal reports from multiple patients state that it is still available in some Indian grocery stores. Many patients receive Kamini in the mail from a variety of sources in India, and there's concerns people from other ethnic groups are now using Kamini given the ease of access. Previous concerns have been raised about the growing popularity of Ayurvedic medicine and the increasing market for these medications, potentially leading to the proliferation of medications such as Kamini without appropriate medical or legal oversight. So, in conclusion, Kamini VIDRAWAN RAS usage is present in the community and possibly underreported. Evident risks include development of de novo opioid use disorder from the use of Kamini, use of Kamini as an additional opioid source by current opioid users, and the contribution to potential harms from opioid use disorder, including overdose. It is easily available through some traditional Indian stores, though there is some increased difficulty sourcing tablets. This is of concern given that as a society, we are increasingly aware of the harm of opiate usage, and we have current prescription monitoring programs such as SafeScript to assist with identifying people who are at potential risk of opioid use disorder. We have a non-prescribed medication that is easily accessible and sold through commercial grocery stores, and the sales are not being monitored or documented as they would be in a pharmacy. There is significant variability between tablets with regards to opioid content. There's limited evidence and literature on treatment options, though patients seem to respond well to opioid substitution therapy. And the limited evidence appears to show that patients respond well and remained engaged with treatment with good recovery capital. And one should also be aware of the case reports and case series of patients suffering significant harms from heavy metal poisoning post-chronic ingestion of some Ayurvedic medicines. So that brings me largely to the conclusion of my talk, and these are some of the references that I've used. And I'll stop sharing slides. Thank you.
Thank you so much, Thileepan. Before we get started with some questions, I know I've got a couple ready to go, and I'll just remind everyone that they can put their questions or comments into the chat box or the Q&A box. Either way, we will notice them. And you can also feel free to raise hand to have your microphone unmuted and join the conversation at any time. I'd love to hear from anyone on the call today who has had experience treating patients or experience with patients who perhaps weren't aware of what they were actually purchasing or taking as part of their Ayurvedic routines. Thileepan, I guess my first question is, it struck that obviously it's predominantly men that are showing up in the case reports, and you linked that back to the idea of using this for libido enhancing or erectile dysfunction. So I was wondering if there was anything happening at an in-community level around efforts to increase awareness or minimize harms, to get some education within communities who might be accessing alternative therapies that they feel are safe or reputable, but that they perhaps don't fully understand or appreciate the ingredient list. I wonder if you could comment on that.
Yeah, there has been, especially over the last few years, there has certainly been efforts in the media to highlight the harms of Kamini, and especially around SBS News had a multi-piece series about the availability of Kamini in Indian grocery stores and the outreach effects, especially in Punjabi language media, about the harms associated with Kamini, as well as the risks of dependence, both from an opioid usage point of view, but also the fact that it can lead to dependence and opioid use disorder. So there has been some media and broadstream media out there. But we are still seeing large numbers of patients coming through. And I was talking a few months ago to one of my colleagues, addiction psychiatrist colleague, and he reported that he'd been seeing many ride-sharing drivers who were actually using Kamini as kind of like a stimulant prior to driving as well. So the usage, I think, is underreported, and I wouldn't be surprised if in coming years, particularly with the restriction of prescription opioid medications, that we might not see an increasing rise in this unsanctioned opioid medication.
Yeah, wow. So in terms of the case series, you presented a couple of case series that seem to be kind of the comprehensive report of what's in the available literature at the moment, if I'm understanding correctly. And I noticed that yours obviously came from Western Health, and somebody's actually asking if you wouldn't mind sharing the link to that case series. And I just wonder, because the other one I saw, I did see a name familiar. I saw Jeremy's name on one of the other case series. So is this an across Australia issue? Are there pockets? What are we kind of seeing?
So Jeremy's case series was from Queensland, and he presented 12 patients as well who were dependent for Kamini, and we're in Victoria, and we presented our 12 patients as well. So I think we could pretty safely say that it's an across Australia issue as well. This is a medication that is something that's widely available in many Indian grocery stores in particular. So this is not just a geographically localized issue in Australia. This is something that is most likely Australia-wide, and it's a substance that's well known in the Punjabi community in particular. So we're talking about that North Indian Punjabi region. So it's not endemic just to Melbourne or Brisbane. It's an Australia-wide thing, we suspect.
Right. And Joe has a question here. He's wondering, or she, Joe, is wondering if any of the clients started on OST went straight to Depo-Bup, or did they all follow current management guidelines, starting with methadone or Suboxone and then transition?
Most of them started with Suboxone, and we then did a transition to long-acting injectable buprenorphine. We didn't do any direct inductions per se, and that was usually out of a patient preferencing rather than us not doing the direct induction. For most patients, they were a bit uncertain about the medication and uncertain about Depo per se, so it was a bit of an easier conversation to just commence sublingual Suboxone as a start.
And we have a raised hand here from Lila or Layla. If we could unmute, could I ask admin to unmute Layla? And feel free to join.
My name
on
is
camera.
Layla, actually. I'm the staff specialist from SUSLAD.
Nice to meet you, Layla.
Yeah, so thank you. So we are seeing cases at New South Wales. So it seems that something is national-wide happening, and we are seeing it in different kind of communities. It's not only the North Indian community, we are seeing it. My question from you and Western Health is that, are you sending these tablets, are you seizing the pills and sending it for TGA analysis to see what exactly is inside the tablets that is going around in national-wide, or you're just not seizing it from the clients and not sending it to TGA? And my suggestion would be, if you're not doing so, to do so, because it looks like it's a public health issue at the moment with the heavy metal inclusion in the pills.
Thus far, we haven't been impounding tablets, mainly because the patients haven't brought any of the tablets in with them to the consultation. So they state what they're using, and we treat them as we see them. So as a routine policy, currently at Western Health, we haven't been impounding or analysing the tablets, but certainly an interesting suggestion, and I'll certainly bring it up with our head of department to see where we go forward with our patients with Kamini dependence.
Thank
Layla,
you.
have you had that opportunity at all?
Yes, we did.
You
so
have.
we are writing a case in regards to this at the moment, and the TGA is actually getting the tablets off us and analyzing it. So it's quite interesting that our case is quite different in case that it was presenting with kind of, symptoms to hospital, and then we started him on treatment in our section. So Yeah, so watch out for this spite and see our
Yeah.
case is coming very soon.
So just for curiosity, Leila, so the TGA was responsive in terms
Yeah.
of reporting back to you what they found?
No,
Excellent.
well,
How
they
interesting.
are going to be responsive, so we are going to send the tablets to them. We have the PLCs, so it's going to be sent to them today or tomorrow, and hopefully we'll get the analysis back in 2 weeks.
Yeah, wow.
Yeah.
That's great. We'll definitely watch out for that. And future Daria seminar right there.
Yeah.
Excellent. Thank you so much. Thanks, Leila.
No worries.
Anyone else with any experience or relevant current cases that they'd like to share? Please feel free to raise hand or unmute yourself, or I think perhaps you might need to put it in the Q&A and I can ask for you to be unmuted. Thileepan, thank you so much. I was just wondering, one other thing was if there was any sort of clear view on the supply and source coming through around, I mean, you're suggesting that it's well known to Border Forest or Home Affairs and yet still clearly stocked on the shelves. What do you see as the next, what's happening there?
It's an interesting one, and this is without a strict evidence base. So I'll just flag that right now. But some of the media reports say that the source of the Kamini for the Indian grocery stores is actually some of the wholesalers they buy other products from as well. So say lentils or rice, the same manufacturer or is the source of the Kamini as well. So it's all brought in bulk. So it's going to be really about looking through some of the importations that's getting done, both the food substances and whatnot, if we're going to try and restrict the flow of Kamini into Australia, because some people have mentioned that some of the store owners have mentioned that they feel that they're being strong-armed into providing Kamini as part of the other substances they buy off the wholesaler as well. So it's an interesting dynamic. It's not just the Indian grocery stores are buying Kamini separate from their other supplies. It's part of the same supply chain. So it's an interesting dynamic in terms of that. And I think that's where the difficulty in regulating the supply is. But it's got a lot of problems, not just the opiate content in Kamini, but also the heavy metal content. And it's something where we do need to be vigilant for, because the supply is out there, and as per our patients, it hasn't really significantly decreased all that much, which is problematic.
Thank you. That's all so interesting, and I'm sure that I'm joined by all of our attendees today in thanking you, and we look forward to hearing more. I think it sounds like coming up. The other thing as well is just to refer back to your podcast. They're great, really good bite-size podcast sessions, and they're great for clinicians at every level of healthcare provision. I'm also going to just mention next week's Daria presenter, who will be Dr. Jamie Berry, who will be presenting on alcohol and drug cognitive enhancement program. And before we finish and sign off for the day, I'd like to just remind everyone that there will be a recording available of this session following the session. It will be freely available for you to revisit or share with colleagues, consumers, clients, or any peers that you think may be interested. You'll find it on the NCCRED website within the next probably 24 hours. And I look forward to seeing you all here again next week. And again, if we can all take a moment to thank Thileepan and have a lovely rest of the afternoon. Thanks, everybody.